Welcome to Top Med Talk. The Society of Cardiovascular Anaesthesiologists annual general meeting is coming soon. Check out scahq.org now. More details at the end of the podcast.
Top Med Talk.
Welcome back, everybody. We're going to begin introducing a really great breadth of panelists and a patient who used to be a surgeon but can speak through multiple lenses on the topic of is day case total knee replacement taking ERAS too far? I think it's a timely conversation, certainly in lieu of all the economic tensions that we're facing in the delivery of healthcare. So I'd like to bring in my panelists in studio. Desiree, do you want to introduce our guests?
Yeah, thank you so much, Saul. So Saul is in the comfort of his home over in America, but we're holding down the fort here, doing EBPUM Ireland, and we thought we'd bring in some of our guests from here in the studio. So first, David Howard, thank you. Thanks so much for joining us. Just give us a little bit about your background.
My initial internship residency, it would be called in the States, was 6 years in general surgery and orthopedics. And the best orthopedic teacher I had was a man called Alan Graham Apley, probably the best teacher of any surgical discipline. But for reasons I won't bore you with, I then did a residency in ENT and head and neck. So I'm not completely retired, but I'm officially a head and neck oncologist. But 11 weeks ago, I had the medial compartment of my left knee implanted here in London. That's a very recent event, and if anybody would like to hear my views on the day case situation, I'm happy to tell you.
I think we absolutely would.
Honestly, we will want to hear your views.
That's right. We strive to always hear patient voices. It's sometimes hard to do that. So having the lens of, the medical side, but also now the patient side, I think the perspective is going to be really, really fantastic to hear.
Well, ENT in the UK, our move to day case surgery now goes back 3 decades. So I've had a lot to do with the debates that have gone on over the years. I'm working in a small specialist hospital with a superb group of anaesthetists. I mean, we're talking ultimate airway anaesthetists here. Yeah. We did manage to change to very substantial procedures as day case, depending on what you call day case, because people kind of cheat.
Yeah.
If you're talking less than 23 hours, but if you're talking in the morning and out in the evening, that's different.
Yeah.
But an overnight stay and discharge the following morning, as long as it's within 23 hours, depends what you define by day case.
So it's a drive-through versus an overnight. Well, I think the perspective is going to be good, and love to hear kind of what your experience as a patient going through enhanced recovery and the different elements that you felt were really important to you.
They are similar to the requirements for ENT day case. Yeah. I mean, it's all about patient eligibility. It's all about you having a clear program, a multimodality team, everybody tuned in, analgesia of high quality, et cetera, all the things that I'm sure you're going to talk about.
Yeah, absolutely. No, what a great perspective. And then we have Brian O'Donnell. Again, for those who may not have seen you before, tell us a little bit about your background.
Great, Desiree. I'm a consultant anaesthesiologist at Cork University Hospital. My area of real interest is in regional anaesthesia and the education around that. However, I have taken on the mantle of joint clinical lead for the pre-assessment, pre-admission processes within our hospital. I've also had the dubious task of setting up our prehabilitation program for colorectal surgery. So this fledgling program is sort of under my stewardship at the moment. That's kind of my oversight into perioperative medicine. When it comes to arthroplasty, orthopedics is a significant proportion of my clinical practice. Weekend warrior endurance athlete. I was out for a bike ride this afternoon, actually, around the Dingle Peninsula. This is definitely the way to do a conference. Because we had the conference in my headset while I was 90 kilometers around the peninsula on my bike. So that I can highly recommend a trip to Dingle, being present while not being present. It's a really good way to do it.
By the way, everybody, that was a totally unsolicited
plug for next year's meeting.
But it's true, Saul. It is absolutely true. And I may need to be one of those individuals in a couple of years' time needing a joint replacement surgery as I'm grinding articular cartilage in my right knee from an old rugby injury. Again, the perspective from the panel this afternoon might actually inform my choice going forward as a patient. So, yeah,
that's a great segue to bring in our next panelist, Dr. Vinod Dasa, our resident orthopedic surgeon, to speak to this discussion through that lens. It sounds like we're all going to need you eventually. So why don't you go ahead and explain to all of us who you are and what you do.
Dr. Dasa, I'm an orthopedic surgeon. I'm the vice chair of orthopedics at LSU Health in New Orleans, Louisiana. And I'm also the director of research for our department as well. We've been doing outpatient knee replacement since 2013. And by outpatient, I mean leaving within the same day as the surgery. And then recently, when we came back from COVID in mid-May of 2020, a little over a year ago, we started doing opioid-free outpatient total knee replacement. So on discharge now, patients only need Tylenol and NSAIDs. And so we've just submitted a couple papers around that within the last couple weeks. So happy to discuss our experience, happy to discuss the research. It's multifactorial. There's a lot that goes into it: patient engagement, education, clinical alignment between all the stakeholders. A lot of things you have to consider if you want to move in this direction.
So let's go ahead and jump right in. I think it's clear that we can do it. You obviously are evidence to that. I want this conversation to focus on more the question of whether or not we should do it. Now that we've declared it possible, is it the right thing to do? And obviously I'm baiting the discussion, but let me sort of start by asking our resident patient in the room, what were your perspectives about wishing to do it or reluctance to do it? And now that you've had a knee procedure, what are your retrospective thoughts on it? So if we could just begin the discussion to ask our patient to speak to his experience.
I was very happy to do it with a past knowledge of the benefits of day case surgery. My concern, I had excellent preoperative information, care, preoperative physio assessment, which was of the highest quality, superb information from the surgeon, plus some knowledge of my own, but that could have been given to me by the team. My one concern was my age and comorbidity, because when you're talking about the surgery, of course, you have to talk about the anaesthesia. And I knew that I was going to have a spinal anaesthetic, and my concern was borne out subsequently because I went into acute retention, despite superb care, early mobilisation, all the things that you can read about in the literature. And I'm sure Brian will fill us in on the joys of prilocaine and all the debate that goes on about 20% and 40% and all the rest of it. But the fact is that round about a quarter of people in my age group, male and female, run that risk of that comorbidity, and that one thing kept me in longer. And then with regard to the post-op, my wife is a professor of surgery. I knew she would collect me in a car where I wouldn't have to bend my knee a great deal, and she would look after me when I got home. So it's pre-op, peri-op, and post-op, and that is always the case. So I've always felt that day case it's not a day case, or, I mean, you're basically 1 day, 2 days, 3 days doing joint replacement, and it depends on the patients. But I was very prepared to get out in 1 day.
Fair enough. And I think you represent a very, I don't want to say unique, but an important demographic where there's medical literacy that would be extraordinary because of your background. Vinod, speak to the importance of patient education, training, medical literacy, if you will, to identify that patient, not so much with respect to their medical health, we'll get into that in a second, but just in terms of their preparativeness culturally and behaviorally to accept the phenomena of drive-through knee surgery.
I was also familiar with the fact that opioids are not required for an awful lot of surgery. You may receive intravenous opioid during the procedure, but afterwards a combination of what we call paracetamol and NSAIDs, in my case ibuprofen, provided the patient takes them regularly and with food, etc. They are sufficient with a lot of modern arthroplastic surgery.
Yeah. So I think David brings up a great point because he's well informed. And so one of the key components of this is patient education and patient engagement. Because I'll tell you, if you want to go down this path, it requires the patient to buy into it and understanding kind of what this entails. And so we spend a lot of time with patient education. So we have quote unquote joint camp about 2 or 3 weeks before surgery where the patients come in. And it's actually in our situation run and managed by our physical therapy department, our inpatient therapy department, because actually they are kind of a linchpin to a lot of what happens pre and peri and post, because obviously they're doing therapy post-op as well. So they have a nice vantage point in how the patient does because they can marry their social circumstances with their clinical circumstances. Transportation is a big issue for a lot of especially older patients. And so I think patient education is extremely important to get their expectations at the right level, because if they think that they're going to be staying 3 days, then guess what? They're going to be staying 3 days. It doesn't really matter what you say or what anyone else says. So I think the surgeon or whoever is kind of in that initial meeting in the exam room, in that preoperative discussion, sets the stage. And so that's extremely important. And whatever tools and resources you can give the patient so they can become informed and improve their literacy in terms of what to expect, lower their anxiety, because there's a lot of anxiety, especially for, the lay patient, not an ENT surgeon, but, the typical patient, they can't make heads or tails of a lot of what's going to be coming down their way. And so if you can really boil that down into bite-sized pieces, manageable amounts of information, it really helps with the process that they go through.
When or how do you red flag a patient who you think, ideally through a lens of medical health, wouldn't qualify from a lens of behavioral health? What is your trigger to say, oh gosh, this isn't a candidate based on your perception of how well they would tolerate the concept?
Yeah, so I think there are a couple key components. Number one, are they medically optimized? So do they have chronic diseases that are optimized and that don't require hospitalization? So for example, a dialysis patient, right? I think that's one extreme. That's the obvious one. The other ones are around social support and transportation. And so, do they have adequate social support? Here in the US, it's also a function of day surgery or inpatient surgery, and then now it's site of service, right? So is it the surgery center versus an inpatient hospital? So in the US, you've got kind of two buckets that you have to start thinking about. So are they, number one, a candidate for the surgery center versus the hospital? And then if they're in the hospital, obviously you have the luxury of if they need to stay overnight, they can. If they don't, then we can send them home the same day. So the struggle here, not the struggle, but the challenge here in the US is, who's a candidate for a freestanding surgery center, and then who should be done in the hospital, both of whom can be outpatient, but you still have the benefits of the facilities and the expertise that you have in the hospital. A lot of practices here in the US are creating algorithms in terms of who we can funnel to the ambulatory surgery center. And those function around their medical optimization. And for chronic diseases, are those disease states amenable to being done in a surgery center? And then also the social support. Do they have the ability to get home and not require additional services like you would get in a hospital?
Brian, do you speak to the role of the anesthesiologist or the preoperative, if you will, provider to address those concerns, to ensure that the patient's healthy before surgery? And then also, I would like you to speak to the point that David raised in terms of what do you do as an anesthesiologist during the actual procedure to mitigate those potential, if you will, adverse events that may derail the intent of a same-day procedure.
So would you mind breaking that down into two components for me?
First question is, through the lens of preparation, how do you address the patient and tee them up, if you will, to ensure that they're best suited for the challenge, if you will, of a same-day procedure, given their medical conditions?
Initially, it's a complete history and physical examination. That essentially is the initial interaction. From there, very targeted investigations, specifically in relation to functional capacity, evidence of metabolic end organ dysfunction for diabetes, ensuring that HbA1c, etc., is below a critical threshold. One of the discriminating factors, we don't have access to the likes of CPET testing, and I'm not certain how useful this would be in this cohort with significant knee osteoarthritis. However, the ability to ambulate independently and climb a flight of stairs without significant functional limitation is one of those clinical discriminators that we would use on a regular basis. I'll couch all of this by saying that specifically we are not currently looking to establish pathways within our immediate environs for ambulatory day case, either 23-hour or same-day discharge knee arthroplasty surgery. Our current length of stay is about 2.5, 3 days at most, and our ERAS program is pretty much stretched to its limit as it stands. I'm actually really interested because Vinod and his center have been doing this since 2013, so they're obviously doing something right. If 8 years later, they have a program that is discriminating between patients that probably should stay under the care of the inpatient environment for a window, and a discriminator that would say, yeah, look, that ambulatory care center down the road, we work there too, we manage that, we've got these same quality standards that apply there. You predictably will be that individual. I'm really interested to hear, not just to throw a question back, but I'm really interested to hear from Vinod as we progress the conversation, what that discriminator actually is.
Yeah, no, perfect, because I was thinking the same thing as you answered. There, culturally, it's interesting in that you have settled on the 2.5, 3 day length of stay acceptance, and Vinod obviously has been much more, I'll say, progressive in their thinking about how to push that. I'm sure it wasn't random. I'm sure there were some discriminating triggers that helped you differentiate who could and who should. We saw this morning discussions about anemia management, nutrition, screening and management. What are those discriminators, Vinod, that separates the wheat from the chaff?
Yeah, so I think part of it is a function of your practice and the types of patients that you see. Brian hit on it. So number one, end organ disease and optimization, right? So if they've got heart failure, kidney failure are going to be the main ones, then no, the answer would be no. Or you anticipate, maybe doing them in the inpatient setting, but you'll see if they can qualify to go home the same day or stay overnight. Number two, and so just as a frame of reference for the audience, if you go to Journal of Arthroplasty and JBJS, those are the two main journals within the world of orthopedics. There are probably at least 5 or 10 journal articles now outlining different risk calculators to identify risk factors for outpatient versus inpatient surgery. So there's a fair amount of academic research in this space now to help you kind of figure out who those patients are. But there's kind of a practical formula, which is number one, age to a certain extent, social support, and then like Brian had mentioned, end organ disease optimization or how far along they are in that process. For the most part, if they're relatively healthy, so they've got no heart failure, no obviously dialysis or anything like that, they've got social support, so they've got a family member or enough support to get them home and transportation. Remember, for example, poorly controlled diabetes, a hemoglobin A1C of 7.5 versus 7.9, that's not going to impact your functional ability to leave the hospital, right? So what we're worried about in a lot of those, or, if you're somewhat anemic or have low albumin and nutritional issues, that's not an acute issue that's going to prohibit your odds of going home. Those are issues we worry about for long-term outcomes in terms of infection and instability and things like that. The two main factors really are pain and functional ability, right, after surgery. So if we can manage your pain, if you got quad strength, then you're going to be in a reasonable amount of shape. And so now do the other pieces of the puzzle fit allow for you to go home. So, because if you're miserable pain and you have quad weakness, you're not going home even if you run an Ironman, right? Even if you're Brian, if your pain score is 10 and your quads are shutting down, you're staying, period, right? Or let's say you're on dialysis and heart failure, and we've got these kinds of patients that I could be doing outpatient surgery on, where they have virtually no pain and they're walking 300 feet without barely using a walker, but they're on dialysis. So does that mean we're forcing you to stay because you're on dialysis? So we're at that point right now where if you can get the quad function, you can get their balance and all those issues squared away, and their pain's well controlled, then their medical comorbidities, start becoming more or less relevant, and my goal is to get the surgery almost to a point of a knee arthroscopy or an ACL where, we don't question, even if you're on dialysis, that you'd go home the same day after an ACL reconstruction, right? Not that that happens too frequently, but, so I think it's a moving target, but I think at baseline, pain and function need to be established before you even start thinking about all these other medical comorbidities.
Most centres around the world, whatever day case surgery they're doing, have instituted scoring systems. And that scoring system is a multimodality one. It's not just anaesthetic colleagues or medical physician colleagues. It's things like the clinical nurse specialist interviewing the family to see what the facilities are like at home and what the transport is to home. It's the dietitian looking at that's particularly true in head and neck oncology. And it's, in our case, the speech therapist talking to the whole family. Because very often when people return home after laryngeal surgery, it's not the patient who's bothered, it's the rest of the family who are bothered. So it's a multimodality scoring system to see if the patient and the family are up to day case surgery, basically.
And actually, Saul, go ahead. I was just saying that really addresses one of our Slido questions. Are you not just shifting the burden of care to the family and negating your duty of care?
Well, I think it's a good point. I'm going to turn it over to you to manage this, Slido, in 1 second. I just want to make a quick point, which is this. It begs the question about how we've tended to loosely define enhanced recovery after surgery to be misinterpreted to enhance discharge after surgery. And I think we lose sight of the fact that we're really looking at enhanced recovery, irrespective of where that recovery takes place. And I think it's important that we don't lose sight of those two definitions. Brian, one quick question, and then I'm going to ask Desiree to go through our Slido deck. David did mention that he had some urinary retention after surgery, and that preempted, if you will, the opportunity for a rapid discharge. What do you do as an anesthesiologist intraoperatively, just in terms of management, to enable a rapid discharge? I know you're still in the 2.5, 3 day sort of domain, but should you evolve to same day? Teach us what we can expect an anesthesiologist to do to enable that to happen, both through what you do intraoperatively and what you may do immediately perioperatively with respect to pain management.
Sure. I guess the two main things that come to mind immediately are number one, carefully select both the dose and the agent that's used for intrathecal anesthesia. At Cork University Hospital and at our elective site, we are currently using bupivacaine, and we're currently using, for our inpatient pathways, we're currently using between 12 and 15 milligrams of intrathecal bupivacaine. So that's 2.5 to 3 mils for your standard arthroplasty surgery. It is very much possible to use a dose-sparing technique with the addition of very minuscule amounts of intrathecal fentanyl. We've slowly moved in terms of, and COVID was one of the great excuses to use prilocaine in our practice, specifically for day case gynecological surgery. And we found that with our day case gynae surgery, that urinary retention really was a problem for a very, very small number of people I don't actually have data, but it is in the order of sort of 3 to 5%. And the very rapid recovery meant that the women undergoing ambulatory, largely hysteroscopic pelvic surgery were self-caring within about 90 minutes and ready for discharge at 3 hours. I think that the number one, avoidance of opioids or opiates systemically, and number two, very carefully titrating the dose of intrathecal agent.
I think it is useful to talk about what the process actually kind of looks for you. Like, what is your pathway for enhanced recovery for your patients? And specifically, is it a spinal? Is it an adductor canal block? Is it, what type of regional you're doing? Just kind of briefly run through that quick. And Vin, I'll start with you. Do you think that your pathway looks a lot different? And if it does or doesn't, do you still feel your patient outcomes are probably as good?
Yeah, so it all starts with me in the exam room and laying down the foundation. Then we've got a joint camp scheduled about 3 weeks-ish before surgery, where they meet with a therapist. They'll start learning the exercises. They'll start, the hospital staff starts explaining kind of what the experience will be. We've got an online platform that we use to engage the patient. We've got quizzes, we've got videos, we've got tutorials. What are they going to do with planning for groceries and things like that? Who's going to help them? So all those kind of questions and all those logistical issues we try to address on the front end, with the theory being there should be not a question that the patient has going into surgery. You've had 4 weeks, 8 weeks, 12 weeks to plan for the surgery. There should be no question left by the time you hit the door of the hospital. So joint camp at T-minus 3 weeks. We do cryoneurolysis about 1 week prior to surgery, AFCN and ISN. Day of, we have multimodal analgesia, as expect most people are doing. We use Lyrica. We've got Celebrex, Celecoxib. We give oral TXA preoperatively. And then if I could, I'd give TXA as an infusion, but my anesthesiologist would throw me out the window if I force him to do that. Then we do long-acting bupivacaine for our adductor block. We do spinal anesthesia intraoperatively or periarticular injections. Do a few other things during surgery to minimize blood loss and things like that, which I think help. No tourniquet, I think, is important for me in improving their pain and function after surgery. TXA during and in recovery. And then, a few other things. So that's kind of just a global perspective.
I'm actually going to reflect on my mum had a knee replacement 3 years ago at our institution. So I'm just going to reflect on her pathway. Once she left the surgical black box, that was the outpatient or the rooms clinic where a decision was made to surgery and she received the surgical information. I can then speak to the fact that she received a telephone assessment from our perioperative clinical nurse specialists. She then attended in person for a series of targeted investigations. She then received information about how the hospital works and what she could expect from the moment of admission to the moment of discharge. She met with physio and with occupational therapy to assess her needs with regard to discharge to ensure that at day 2 or day 3 that her home supports were adequate. She had a spinal anesthesia. Our surgeons are still using leg compression devices, so she had a tourniquet inflated for the better part of 90 minutes. She received a tranexamic acid intravenously before the tourniquet went up, and then a 2nd gram once the tourniquet was down. Spinal anesthesia, probably with 2.5 mils of intrathecal bupivacaine. She received an adductor canal block. We routinely prescribe an opioid, and dare I say, oxycodone is our go-to oral agent in our recovery room. We prescribe a gabapentinoid, so pregabalin is also prescribed for 5 days, as well as acetaminophen or paracetamol, and a non-steroidal of choice. Usually it's diclofenac or ibuprofen. She had a pretty uneventful recovery, was mobilized on the evening of surgery. The following morning, her thromboprophylaxis was started, and thromboprophylaxis was then continued for 2 or 3 weeks post-op. Her gabapentinoids, opiates, and other oral multimodals were continued for the first 7 days. And pretty much after 7 days, she was self-ambulating, self-caring at home. But for the first 72 hours in considering this panel discussion, again, a plug for Top Med Talk, and listening back to one of the conversations with Henrik Kellett and Nick Scott a number of years ago, discussing inflammation. So total joint arthroplasty is not a small surgery. It is a significant day out where several osteotomies are performed, and the inflammatory cascade that this sets up really does lead to a profound systemic pro-inflammatory state. And I don't think that as healthcare providers we can underestimate the fatigue that people feel. So you're assuming that the individual will be in some way capable of heading into their own home and being some way functional in that environment. And that's actually one of the questions that I'd like to now segue into with David, to identify, were you just exhausted for a couple of days after you've had?
I was fatigued, and although my knees are good, but I've done a huge amount of marathon and ultrathon running. My joints are okay. I injured the medial compartment of my left knee. That was why I required the uni compartment replacement. But I felt as if I'd run a marathon the first 2 or 3 days, and that is the general systemic effect which you have just described, and people underestimate that. But again, you have to explain that to patients and to their loved ones, otherwise they go home very worried. I had 2 practical considerations. The one I'd like to ask Vinod about, because I haven't been able to find any evidence for it. As an orthopedic surgeon, I was always taught about quick mobilization, good muscles. It's all about keeping your muscles in shape. But the most painful aspect of knee arthroplasty in the first 5 or 6 days is this great desire for flexion, which the physios talk about all the time, and, quick mobilizing gets much fun. And obtaining that flexion early is very painful. And I can't find a reason why you have to have flexion in the first 7 days post-op when your knee is edematous and bruised. I fully understand that ultimately, the long term, you've got to get the best flexion possible. But there's no requirement for it in the first 7 days. I mean, we all know if somebody's got their leg stuck in plaster for 3 months, that's bad news. Now, we all know that immobilization for periods of time isn't good, but trying to get this maximal flexion, whether it's in the pool, hydrotherapy, or whether it's on the bed as a static exercise, I fail to see that it's that necessary in the first 7 days.
And a common piece of enhanced recovery, right?
Yeah.
They're always saying.
Enhanced recoveries, don't try and flex your knee in the first few days.
We want you to earn your surgery. That's why.
Yes, it's no pain, no gain, whatever.
So it depends on the philosophies of the therapist that you're working with and the surgeon. So our philosophy is really extension and getting your knee straight. That's
fine.
Maximally important in the early going, because that's the most difficult to get if you wait too long. We can get flexion. That's not.
But it's far less painful too. Yeah.
What's that?
It's far less painful obtaining that extension with static exercises on the bed, but the flexion it's painful. And
it's tough.
Couldn't see any great need for it in the first few days. The other thing that I found of practical use was a game-ready device. Yep. I'm not going to provide an advert for the manufacturers, but the compression and the icing made a difference. My wife, however, hated it because she kept having to go up and down stairs with buckets of ice. But it really was phenomenal in the edema bruising reduction and in pain control.
David, did they use tranexamic acid for your case?
Yes, they did, but I had a great surgeon, but I had a lot of bruising above and below my knee, despite having my normal blood pressure is 110/70, pulse rate resting about 42, 44. I still got extensive bruising.
Vinod, can I get your opinion regarding? So this is an interesting procedure. It's the iconic quintessential elective procedure that we always talk about when we speak about elective surgery is total knee arthroplasty. And some patients require that procedure who are anemic. I would dare say it's more than common. Given the fact that it usually has a long runway, 2, 3, maybe even 4 weeks before the surgical date is scheduled. In this discussion, speaking about the exhaustion, if you will, that is incident to the procedure immediately post-op, and putting the two together, functional recovery of a patient who is discharged anemic, whereby we try to avoid transfusion, versus discharging a patient who is not anemic, is material. And so the question is, what are your views about just fixing the anemia before the procedure electively? We had a nice discussion about IV iron and transfusion avoidance and the consequences that also has on length of stay as well as readmission. But I think another variable that we don't measure yet well is just simply functional recovery and exhaustion.
I think anemia prior to tranexamic acid and a lot of these new modalities was a big problem, right? And so if their hemoglobin was 10 going in, we had this whole erythropoietin protocol, and we spend a lot of time and energy to tank them up, if you will. And that was all because we were worried about them dropping 3, 4, 5 points after surgery. Now, I think with more of these aggressive mitigation efforts like TXA, we're not seeing those drops that we used to see. And so we're not seeing a 4 or 5 point drop after surgery now, 1 or 2 points. I think a lot of people now are a lot more sensitive about blood loss after surgery. I think the surgeries now probably have evolved and are happening a lot faster. They're not taking 3 hours like they have in the past. I think gotten better at this. So I think anemia in the traditional sense, paired with general anesthesia, right, like we used to do, paired with a lot of pain, it's all synergistic and drives that patient's function postoperatively down. So I think anemia as a single point risk factor in and of itself, I think it's when it's paired with all these other factors, they all drive the patient's function down. And so I think anemia in and of itself is not so much of a worry as it used to be. Now, the measurement of the patient's function after surgery, here in the U.S., we're using PROs. CMS, one of the big national payers, Medicare, is moving towards all of us capturing PROs, specifically COOS and PROMIS, which is a general health score. And there you also have sleep disturbance. David probably had issues sleeping, I'm going to guess, for the first 4 weeks or what have you after surgery. And so we're capturing those short-term functional scores. And so we're paying a lot of attention to sleep disturbance and things like that. But we don't have data yet specifically linking individual subgroups in those PROs to specific clinical parameters like anemia. But I think probably the research moving forward will start kind of pinpointing exactly what clinical factors are leading to specific differences in outcomes.
Patient-reported outcomes, right, Vin?
Yes.
ERAS.
Yep.
Yes. Okay, Slido. Okay, we're going to run through a couple of these very quickly. Do you proactively follow the patient searching for early signs of complications? Then I'll start with you as the surgeon's perspective on that one.
Yeah, so every surgeon's got a different postoperative regimen. I see the patients back at 2 weeks, and I rely heavily on my physical therapists or physiotherapists. They are my eyes and ears in the trenches. They probably even know how my incisions look better than I do. If you think about it, your physical therapists are actually spending 3, 4, 5 hours with the patients every week. And so if you train them up and you give them and you empower them to really understand how these patients should be progressing clinically postoperatively, you can catch a lot of these early issues before they end up in the emergency room and more of a problem. So I think, again, it's teamwork. If you're going to go down this ERAS enhanced recovery pathway, it's not just flipping a switch, right? You have to have the whole team with you. And you're rowing in the same direction. You're educating everybody about what to look for. You have an open lines of communication. You don't just discharge the patient into the ball blue yonder and hope for the best. You've got kind of an organized process. So you can monitor these patients postoperatively and be proactive if someone picks up on a problem.
Brian.
Again, I think one of the key enablers is appropriate analgesia and analgesia pathways and ensuring that those pathways are effective. So again, not necessarily on an individual patient level, but on a macro level, as part of a quality assurance program, ensuring that there's audit cycles running in the background to assess the efficacy of the analgesia strategy. It's got to be right for the population. It's got to be feasible within the hospital environment that you're working.
For sure. And then, David, for you, what I find interesting is, what did you feel like the monitoring for you was? I mean, when it came to complications?
It was excellent, the monitoring, just as Vinod described. I mean, the following day, physio, second day, physio, texting, calling, senior charge nurse, what we would call a clinical nurse specialist on my head and neck unit, contacting third day, had to photograph the knee, which is so easy to do now on the iPhone, send the photograph off, then a further check at 7 days. And these are all things, again, in my own practice, and the point that Vinod made, it's a multi-modality full team. You have to have all these people, everybody singing from the same hymn sheet, if you want to achieve early recovery for patients. I nearly said early discharge. Early recovery for patients. You can't just send them home, and it has to be the full family involved. So full team, full family involvement.
Yeah, agree. All right, Vin, what is an acceptable rate of unexpected extended or overnight admission?
That's a tough question to ask. I don't think there's an appropriate rate or inappropriate rate. I think it's a function of a number of factors. So it's not right or wrong to stay overnight or stay 2 days. If that's what you do, then that's what you do. What we're focusing on is readmission rates and rehospitalizations. That's really I think the metric you want to look at. So if and I'm just picking hypothetical numbers, if you've got 100 patients leaving and 10 of them are bouncing back to the emergency room within 1 week because of pain or function or urinary retention or what have you, that's a problem. So that's really the metric I think people should focus on, not kind of what's an inappropriate length of stay. But we do know length of stay is linked with, problems. So the longer your length of stay is, we published a paper recently looking at length of stay and DVT rates. And so what we found was a length of stay, I think greater than 3 days was linked with statistically higher DVTs. Because if you think about it, if you're staying in the hospital, you're not moving. I mean, at least in our hospitals here, you're laying in bed probably for, 18 hours a day. And then the rest, whereas if you're home, guess what? You're moving. You're going to the kitchen. You're in the living room. You're doing stuff. And so, laying in bed in the hospital, in my opinion, is really probably more detrimental than you actually being at home.
David's carrying his buckets of ice up and down the stairs.
Desiree?
No, my wife knew when I was getting better because I went downstairs and got my own ice. But not for the first couple of days, I didn't.
To the point about length of stay, I think what we're seeing to be probably more challenging to decide whether or not somebody is eligible for discharge within the same day or not is site of service selection. And when we make that decision, or whatever tools we use to enable us to make that decision of site of service, and triage them to an ambulatory surgery center, which may not be able to accommodate the prolonged length of stay patient, it's much more difficult to bite that bullet. And so I think that's the sort of point in the algorithm that really is challenging. How do you manage to that?
So I think if you're a surgeon or anesthesia group, I think first get your processes down in the hospital, and get your length of stay down and get everything done in that kind of safety net, if you will. And once you've kind of figured out who you are as a surgeon, as a team, then, transition over to the surgery center and you can learn from the hospital, right? And so what patients in your hands, again, if Mayo publishes a paper or someone in Seattle publishes a paper, how they do something, that may not necessarily fit the way you do it. And your surgical technique and your team and things like that. You have to figure out who you are and what your facility is before you just kind of photocopy what someone else does. So first, get there, I think, in the inpatient setting. You can start sending patients home the same day, learn from that, then understand from there, who do you think you can then shift over to the ASC, to the ambulatory surgery center. And typically, the easiest things to think about, obviously, is age and stamina. Again, if they have, are they medically optimized? Do they have end organ failure? And then social support. I think those are kind of the four key elements. And that probably varies by region and surgical skill and things like that. But if you take those four key elements into account, you can probably start triaging and understanding who potentially could go outpatient, inpatient, and then who can go hospital versus ASC.
How soon do you follow up, and what physio program do you have in place post-operatively? Do you have any hard cutoffs for age? So Vin, I'll start with you on this one, very surgeon focused.
The last part was age cutoff. No. And in fact, age is just a number, right? And we probably all know patients that are 60 years old look like they're 90, and I have 90-year-old patients who are probably healthier than me. And so really, physiologically, where are they? As opposed to kind of what's their date of birth, if you will. My typical post-operative routine is I see the patients back at 2 weeks. A lot of surgeons in the U.S. don't see the patients back until 6 weeks. And really, it's this blind process where they don't necessarily want to see the patients back early because they're so miserable. And so you're kind of just kicking the can down the road. So a lot of surgeons at 6 weeks will see them. Hopefully they're past that initial hurdle of pain and misery. But I see them back at 2 weeks so I can stay ahead of things, check their range of motion, check their incision. And then I don't see them back for 3 months. Because if I can get them out of the gate and they're doing well at 2 weeks, then really, in my opinion, they're going to do well beyond that, knowing that I've got a lot of eyes and ears on them as well with our therapy group. And so that's my protocol. A lot of physicians here in the U.S. have a bunch of different protocols, but typically the bulk of surgeons are first follow-up at 6 weeks and then second follow-up somewhere at around 3 months.
David, what was your experience?
My experience in England is 6 weeks, but from a personal point of view, I've been too busy to have a follow-up. I haven't seen my surgeon yet. I'll get round to it at some point.
Yeah. Well, in the interest of time, I'm going to ask these two last questions. If we could just rapid fire, yes or no. Do your surgeons use local anesthetics, periarticular, and infiltration? And Vin, I heard you say that you guys do this, right?
Yeah, so we do just plain bupivacaine for our periarticular injections, but we use long-acting for IPAC and adductor.
Yeah, and our surgeons are infiltrating levobupivacaine.
And the last question that we have, can you speak a little bit more on cryoneurolysis? And Vin, I know this is something that you are really into, and we probably don't have enough time to go into that right now. But we did do a Top Med talk with you about this, specifically you and Dr. Josh Urban several months ago now. So I think that would be great. But just really, in the interest of time, just really quickly, what is that technology?
So basically, it's a technology where we create a tic-tac-sized ice cube under the skin, and we create a long-acting nerve block for the AFCN and ISN. And those are the two primary sensory nerves for the surgical pain around the knee, incisional pain, arthrotomy pain. And that's done about 5 days in my practice prior to surgery. And we published a couple papers, one showing 45% reduction in narcotic prescriptions post-operatively in the cryoneurolysis group compared to the standard of care.
Very good. Well, you can find out more on that on Top Med Talk. And I'm sure Vin will have lots of information on that as well to reach out. But Saul, back to you, buddy. We're wrapping it up.
So is this the benchmark? Is this the gold standard for what we should expect with respect to enhanced discharge after knee arthroscopy?
Healthcare is changing rapidly, right? And we're all trying to find a more sustainable system. And so, you can put it in the context of COVID and staying in the hospital. But, we've got a limited amount of resources. We've got to be better stewards of, these limited resources. And so if we can do these surgeries more safely with higher quality and improved outcomes, then if this is where the market goes, this is where it goes, right? And there's plenty of research now showing the safety and quality of this. I mean, there are countless papers now, at least in the U.S. There was a paper just recently in JBJS comparing ASA3s, 90-day complications, mortality and morbidity, no different in outpatient ASA3s than inpatient ASA3s. That just got published, I think, 2 weeks ago using a large data set. So, the evidence and the science is, I think, there. This is where things are going. We've evolved, we've improved, and so we're going to keep pushing this.
And Brian, obviously, you're upstream of that benchmark, but in terms of what we can do to ensure patients are optimized before their surgery so that they can have enhanced discharges after surgery. What are you doing? What are you going to do?
What I'm actually going to do is do what John Whittle told me to do this morning. So I'm going to ask everybody, and in fact, the answer to this question, Saul, was at 9 a.m. this morning here in this room, when John spoke to us on rehabilitation programs for patients undergoing major arthroplasty surgery. So So I think rather than summarize his 15 minutes, I think it's about getting the ducks lined up in a row to ensure that major morbidities are well managed, patients' expectations are well managed, and that we have got ourselves set up within the surgical centres to deliver high quality care.
David, last word, patient satisfaction. Take us home.
Extremely happy, provided that analgesia, excellent information, and some close follow-up from your multiple team. And the only other thing I would add in is the same in all surgery. We're talking about evidence-based. I had a quick look at the orthopedic literature before coming here, and there are about 20 good studies up to 2018 on day case, but more than half of them are retrospective. The prospective ones got plenty of bias in them. So the orthopedic community, just like the rest of us, has to get on with some better prospective, randomised, blinded data. And then in a decade's time, you'll really get people saying, yep, this is okay. But until that point, you'll always be struggling.
You are an exceptional patient in that perspective isn't reflective of most of our patients, but nonetheless, very appreciated. I think we're about time to wrap it up. So I want to thank all of you for a great discussion. Desiree, thank you for managing the Slido and adding greatly to the discussion as well. Thank you all for being with us at this 2021 EPOM Ireland Chicago course.
Top Med Talk.
The Society of Cardiovascular Anaesthesiologists' 44th annual meeting is coming soon, and Top Med Talk will be there. If you want to pop along and see us, it's on May the 14th to the 17th in Palm Springs, California. Check out scahq.org now for special offers and more details. Also, if you're not sure if you can make it in person, why not explore the virtual track? Innovation during COVID-19 now means more than 60% of this year's sessions will also be fully available for you online. Check out scahq.org. That's scahq.org.